One of the things that we learned from immunotherapy in the past years, mainly for melanoma, is that the combination of the two strategies, the anti-CTLA-4 and anti-PD-1, probably will increase the long-term benefit. These two strategies are similar but different. What does it mean? This means that while the anti-CTLA-4 works more at the priming level, at periphery of the immune system, the anti-PD-1, PD-L1 works in the tumor microenvironment during the effector phase. And combine these two approaches may increase the long-term efficacy. And as medical oncologists, the long-term efficacy is our main goal. But sometimes in some patients, like the patients with brain metastases or patients with a high tumor burden, we need also early response and fast response. But when we try to reach early and fast response, in the majority of patients, we have a short-term benefit and not a long-term benefit. Having said that, with the combination, what probably we'll have is the possibility to combine the short-term benefit with the long-term benefit, because the power for the combination is to have a high response rate and also a good progression-free survival, and a possibility to reach the 50% of patients still alive at 10 years. Of course, at the moment, we don't have the data at 10 years, so we have just some data from phase 2 trial, dose 69 at 2 years, who showed the possibility to have more than 50% still alive with a flat part of the overall survival curves. Having said that, so the combination at the moment may be translated in one sentence, a fast and furious approach. Fast because this is the powerful of the combination to have earlier, faster and deeper response. And furious because, of course, there is a toxicity. But this toxicity can be managed with the algorithms that we created for the management of the immuno-related adverse event. There is also another consideration. If you look at the data, always of the 069 trial, the EP plus Nivo versus ipilimumab alone. And if you look at the overall survival of the ipilimumab alone arm, it's really interesting to see that the gap with the combination of ipilimumab and nivolumab is just 10%. So this is interesting data because the majority of these patients, 60% of these patients, when progressed from ipilimumab, were treated with nivolumab. So there is a sequence ipi and then anti-PD-1. So if we consider that ipilimumab given after PD-1 can also have the same efficacy of ipilimumab given in first line, and if we think that now we know also that increasing the dosage of ipilimumab we can get more benefit, of course we can also think to a possible sequencing of nivolumab and then ipilimumab, a higher dose of 10 milligrams per kilograms, and probably we can reach similar long-term benefit from this sequence. So the message is that, of course, when we need of a fast and furious approach, of course, the combination is better. But in other patients, patients with low tumor burden, normal LDH, we can start with anti-PD-1 and then give in sequence ipilimumab, and we have a high probability to reach the same long-term benefit. So at the moment, we have very good news for our patient because the strategy to combine or to give in sequence nivolumab and ipilimumab is a really good option for our patients.
So we're very excited about combination therapy in general, and specifically combinations of immune therapy in melanoma. We've seen really great efficacy from PD-1 type approaches, but we always want to do a little bit better. And one of the ways that we think to improve upon PD-1 efficacy is to add ipilimumab to PD-1. And so my talk this morning at the Melanoma Bridge meeting was discussing about how much we know about how much better is combination immune therapy compared to PD-1 alone. Are there certain subgroups of patients that have the most benefit? And how do we reconsider one of the limitations of combination immune therapy, which is toxicity? Unfortunately, there is more toxicity when you combine ipilimumab and PD-1 approaches than just giving PD-1 by itself. But many patients that have this toxicity, fortunately, do have complete resolution of their toxicities with immune suppression, like steroids or the TNF alpha blocking antibody infliximab. And so many of these patients will have this benefit. They will have some toxicity, but long-term they can remain with very good disease control or in long-term remissions, even without ongoing treatment and after management of the toxicity that they may have had. So that is one of the discussion items that we had today. And really the ipilimumab and PD-1 combination is really just the first of what I expect to be many combinations for treating not only patients with melanoma, but many different types of cancers with the various different immune therapy combinations. We're seeing more and more and more combinations all the time. And one of our challenges moving forward will be trying to find the best clinical trials where we can test these combinations. What are the right endpoints? What are the certain kinds of patients that we should be treating? And how can we really move the field forward as quickly as we possibly can to help our patients in need?